Okay. All right. Okay. All right. Hey, welcome everybody to the Arthro School webinar on the patellofemoral joint. My name is Lee Pace. I'm listed as James Pace, which is my first name, but I go by Lee, which is my middle name. I am an orthopedic surgeon in Plano, Texas, America. I have a unique interest, along with our other speakers today, in the patellofemoral joint. I have a lot of these people to thank for my interest in the patellofemoral joint. I've got the easiest job today. I am simply the MC, so I get to introduce the people that have done all the work to prepare what are going to be great talks for you guys. So the order for today's webinar is we're going to start off with Petri Silanpaa, who is an orthopedic surgeon in Finland, who's going to discuss compensatory management with MPFL Reconstruction. And then next, we're going to have David Dejour in Lyon, France, who's going to discuss trochleoplasty to treat high-grade trochlear dysplasia. And then lastly, we're going to have Laith Jazrawi, who's in New York, discuss cartilage resurfacing options for the patellofemoral joint. So if you guys have questions, please enter them. And we're going to spend the last few minutes of the webinar answering any questions that the audience has. So with that, I'd like to welcome Dr. Silanpaa to get started. So Petri, if you can share your screen, we can get into it.
Perfect. Okay. All right. Thank you for the kind invitation. My name is Petri Silanpaa from Tampere, Finland. It's afternoon here, early evening in Tampere. I work in a private practice, quite focused on patellofemoral patients, and of course I feel honored to be a part of this distinguished faculty. Of course, thank you Arthro School for organizing this. My talk is about when is the MPFL reconstruction alone necessary to treat recurrent patellar instability. Nothing to disclose on this. Physical examination, firstly, very, very important when seeing patellofemoral instability patients. From all the clinical tests, the single most important, I would say, is the patellar tracking evaluation. This evaluation can only be done when patient is sitting on the edge of the examination table, the quads activated. You can't do this on supine. It's very important to evaluate how is the patella tracking. And in these extreme cases on the right and middle, you can see highly abnormal patella tracking that indicates bony abnormality in the patellofemoral joint. So whenever the patella lateralizes in extension, it's called J sign, and the presence of the J sign indicates clearly abnormal bony abnormality, and perhaps not a case suitable for isolated MPFL reconstruction. And it's also very important to understand that the patella tracking is guided by purely bony anatomy, and you cannot pull the patella medially. You can't address this kind of J sign with soft tissue reconstruction only. Theoretically, in an attempt to do so, basically you would have to overtension the medial restraints, which will eventually either fail or prevent a pain-free range of motion. So in other words, the only surgical solution in this kind of highly abnormal jumping J sign is bony surgery. So what if we have done an MPFL reconstruction and the patient still presents with J sign post-operatively? It has been shown that it's correlated with worse patient-reported outcomes, higher percentages of patients with a post-op apprehension, and lower return to sport rate. So therefore the J sign is very, very important. So how can we actually define the J sign, if it's present or not? It's not easy. In a recent study, it was found that the accuracy of the visual assessment of patella tracking is unfortunately poor. The sensitivity and specificity, it's still not as it should be, and therefore it kind of remains still in the eyes of the beholder. That's the challenge of the J sign. So do we have something else? We do have reversed dynamic apprehension test. I personally very much do like this. So we start in an inflection and then we extend the knee and lateralize the patella, and we assess the range of motion in between the test is positive. And for example, in this particular case, we could see that it's somewhere between 0 to 30, indicating an isolated MPFL reconstruction case, probably without any major abnormalities in bony morphology. And this has been proved to be pretty much reliable and therefore very useful in these patients. Well, in addition to physical examination, even though being the most important, we do need some radiographics, and I would say the MRI is mandatory for lateral patellofemoral dislocation diagnosis and the assessment of surgical management strategy. Each individual is more or less different. So we can see from the MRIs the anatomical factors, whatever is the patellar height, what is the trochlear geometry, what is the rotational or coronal alignment of the affected limb, and they all do affect the patella stability to very high extent. So to focus on the most important, I would say the patella alta, trochlear dysplasia, rotational abnormality. Which could be the thresholds? It's very difficult to say. We have some challenges and difficulties in determining the correct measurement tools. But who could fit for an isolated MPFL reconstruction? In my practice, I would say it's of course normal or moderate patella alta, Caton de Champs below 1.25. Ideally no J tracking, or it could be a bilateral J tracking and only the one side is affected. That could work. So how about the trochlea? If we do see a flat or convex trochlea, it's a clear case that there's a J tracking and therefore it's not suitable for isolated MPFL reconstruction. And whenever the lateral trochlear inclination angle results less than 10 degrees, could be a risk factor for to add something bony procedures other than MPFL reconstruction only. How about the alignment? This is a classic case of a squinting patella, where there's typically increased internal torsion of the femur, and it could be also increased external torsion of the tibia. On the bottom right, there's a unilateral case on the right side, and these might affect the patella tracking significantly, and therefore if we do have a very highly abnormal rotational profile, probably isolated MPFL reconstruction is not enough for this kind of patients. So some thoughts about the medial restraints. MPFL being the most important, of course, and MPFL reconstruction. Consider the method of choice to stabilize the patella in terms of soft tissue surgery. What if we try to repair the MPFL? There's a bunch of studies out there that it's quite unpredictable, the results of any attempts of medial patellofemoral ligament repairs. And that is basically because of the fact that when the patella dislocates, the MPFL injury can occur in multiple locations, and therefore repair is unreliable and basically quite comparable with a non-operative treatment after primary dislocation, and therefore not recommended. Not recommended. So MPFL, that's what we should do. I very much like the concept of the medial patellofemoral complex, as you can see in this nice cadaver example. Probably most accurately reconstructed by perhaps quadriceps tendon, MPFL reconstruction, adductor tendon, or double bundle free hamstring tendon reconstructions. Basically, in the literature, we do not have any evidence of differences between these techniques. So to summarize my thoughts on when MPFL is enough to stabilize patella, please focus on physical examination. Any J sign present, it's indicator of bony abnormality, typically trochlear dysplasia or patella alta, and that kind of patient is typically not suitable for isolated MPFL reconstruction. And you can't correct the J sign by soft tissue reconstruction only, it's a bony guidance. In the absence of J sign, isolated MPFL reconstruction is a viable surgical management strategy. Please remember to use MRI. I would say it's mandatory to assess the presence of bony abnormalities, and whenever there's an absence of abnormalities or only moderate bony abnormalities, isolated MPFL reconstruction is the method of choice. Skeletally immature population, still somewhat a challenge, as they typically fall into that kind of anatomy, as you can see on the bottom right. Thank you very much.
Great, Petri. Thank you so much for that. I think that that's very important to know when we should or should not do something. So I appreciate that. And we'll have some questions on that at the end to kind of get into this a little bit more. But we will now have Dr. Dejour talk about indications for trochleoplasty.
So much, Lee, and thank you very much, Arthro School, for organizing this webinar. And thank you, Petri, because you introduced perfectly when we should do trochleoplasty. Definitely, the rationale for trochleoplasty is to change and to make the architecture of your knee better, and probably to improve the cartilage. And when you have such abnormal tracking, no way. You probably have to do or consider trochleoplasty to reduce and to remove the bump. The trochleoplasty is only for dislocation. High-grade trochlear dysplasia, type B or D, the old classification, to remove this big bump that you have at the anterior part of your knee, this preeminence of the trochlea. And the bump is definitely like a ski trampoline. And I always say that this is the biggest pattern for patellar dislocation, but it's also the biggest mistake for a surgeon to miss it, because he will fail the surgery that he will do. And for sure, you have to look at the patella and to look at the trochlea and the patella to the patellofemoral joint. We try to look it with new eyes using the MRI and try to improve. To improve, I work with all my fellows and young surgeons, and we did a fantastic study which really allowed us to make the difference between the different type of shape of trochlea. And you have to make the difference between what is a normal, congruent, what is a flat or convex with no preeminence, or what is a flat or convex with a preeminence. And this is definitely the indication for trochleoplasty is when you have this big bump. So if you look only to the shape, you will see that in the study that we have done, if you say it's flat or convex, but the ICC is definitely bad and wrong, 0.6. So you cannot really rely on the shape of the trochlea, and you need to measure and quantify the trochlear dysplasia. So MRI is probably the best solution because most of the patients are coming with. You see hemarthrosis, lipohemarthrosis, as you have seen before. You see the cartilage, you see the bone and the soft tissue with the MPFL rupture. And you can do all the measurement. What is important is to identify the bump. And the bump, you will see it very well if you have a perfect alignment of both condyles, like on these X-rays. But most of the time, you have bad X-rays like that. The condyles are not on the same line. And if you look on the fluoroscopy, if you turn internal or external rotation, you will be you will see that the trochlear shape is definitely changing, and you cannot really get a right analysis of the trochlear. So if you move to the MRI, you will face exactly the same problem. And you will see the shape, but you have seen that the shape is not really reliable. And the problem is that if you change the orientation of your MRI, you will change the shape of your trochlea. So what is good with the MRI is that when you use a multiplanar reformation mode, the MPR mode, you can realign both condyles and make it perfect, like if you were a radiologist doing a perfect X-ray. This is what is definitely very useful. So trochlea has to be looked at using the 3-plan. And we have many new things concerning this trochlea. What is new about trochlear dysplasia? First, this cranial trochlear orientation. Definitely, you see that the trochlea will rotate on the lateral or sometimes on the medial, and this increases terribly the dislocation pattern. It's pretty tough to measure, but it's interesting to quantify and to look at it. The second is the orientation of your groove. More you have a high-grade trochlear dysplasia, more the orientation of your groove is going medial. It's close to 12 degrees in the high-grade trochlear dysplasia, and it's close to 4 degrees for the control. So when you do a trochleoplasty, you need definitely to change the orientation of your groove. And this is one of the goals of the trochlear display, of the trochleoplasty. So use a classification for looking at your trochlea, and you can use this one, the new one, and which is a little bit more simple than the one that we did before because it goes to normal to high grade. It's a linear classification. It goes from normal to high grade. So it goes to no trochleoplasty to trochleoplasty, and it makes things more easy. So if you use and if you look at this classification that you can use with any MRI in any center, you will indicate a trochleoplasty in the type 3 when you have this big bump and when your trochlea is flat or convex. So this is the best indication for the trochleoplasty. What is important is to remove this bump and this proeminence, to remove this big bump on the X-ray. How to do? You can look at this publication to know exactly how to do. So to understand how it's important is the bump. This is the first step when you remove this bump, and you see how big is the overhanging of your trochlea compared to the femoral shaft. It's you will not accept to do a total knee arthroplasty with such proeminence, so you cannot accept that when you do and when you treat patellar dislocation. The bump is abnormal if it's over 5 millimeter, and also it increased the PF pressure and it increased the dislocation pattern. So this is that you should look at and that you should remove. So when you have abnormal tracking, like you have seen with Petri or my case, definitely this is the best indication for the trochleoplasty. When you have this jumping J sign or the abnormal tracking. On the slow motion, you can see that very well. And this is exactly the patient that you have on the screen. And I show with this example of a total knee, which is pretty interesting. So when we remove this bump, you see that it's huge. You cannot miss it, and you have to do something definitely. So the goal of the second goal for the trochleoplasty is to reorient the trochlear groove. You have seen that it was 12 degrees medial. When you have a high-grade trochlear dysplasia, it's 4 degrees if you go to a control population. So definitely you remove the bump, you reorient the trochlear, and then at the end, you will definitely deepen the groove, as you can see on this video. So of course, your trochlear will be much more congruent. From this one, you move to this one, and it's must be very efficient. And then you have to redo the MPFL because the MPFL is torn, but you don't have to. The MPFL is not there to correct the malalignment. It's just here to make your patella secure on the medial side. So your MPFL shouldn't be over tense. It's like a check rein, as we say. So you see that we follow our patients since the beginning, and we have a long-term studies to present. And definitely, the thick flap technique that I use, it's mostly like an osteotomy, can be done even if you have some cartilage damages. It's a little bit different from the Barreiter technique, where you have a very thin flap, which is for me a little bit dangerous. So what about arthritis? You may say, well, okay, if you do a trochleoplasty, maybe you will increase arthritis. It's not very true. From this very first series that I did, not a big series, 11 knees, 23 to 30 years, you see that most of them had previous surgery. So most of my trochleoplasties are revision surgery, 65%, 64%. And in this series, I was not doing an MPFL at that time. We were doing some TTO, and as you can see, the results is really high in terms of satisfaction because the patients were so in trouble with their knee. Osteoarthritis, 22% E10 stage 4, which is the true patellofemoral arthritis. But if you look on the other knee, it's 22%. So trochleoplasty did not increase arthritis, but it improved dramatically the way of life of those patients. So it's really efficient in terms of quality of life. On this series, 10 to 20 years of follow-up, mean follow-up 15 years. Here again, 62% of previous surgery, and at that time I was doing MPFL. And the results are about the same in terms of quality of life, in terms of stability, in terms of satisfaction. But it's interesting that arthritis was less. And we had no stage 3 or no stage 4 E10 arthritis. So it means that the evolution of the patellofemoral joint after trochleoplasty is definitely not bad, and you can be very confident on doing this surgery. So the risk factors, all the risk factors are so important, and you shouldn't forget them. The TTTG, the trochlear dysplasia, the patella alta, the patella tilt, and also the secondary factors with the rotation. And if you want to win the gold medal, definitely you have to correct all those factors to be fine. So, in conclusion about trochleoplasty, you can decide with your MRI, you can measure, and really I push you to measure, to quantify, to know exactly which patient you have, and then you will be able to address an isolated MPFL, distalization for patella alta, and sometimes, rarely, but sometimes, a deepening trochleoplasty, and you will not increase arthritis. You will give a high rate of satisfaction for your patient. So it's definitely not a salvage procedure, and it should be considered as a primary surgery if the bump is over 5 millimeter in type B or D or in type 3 trochlear dysplasia. Thank you so much, and see you in ESCA probably, and in Patellofemoral study group in May also. Thank you so much.
That was fantastic, Dave. And I think the other thing, I think you're being a little generous. I mean, if you look at your 20 to 30-year study versus your 10 to 20, those 20 to 30s were more revisions, whereas your other study, 10 to 20, those were most primaries. So, that says that this should be a primary procedure for the proper people, and that saving it as a salvage is not the best option for some of these people. So,
Uh,
you know, um, anyway, so Laith, thank you. So now I want to introduce Laith Jazrawi. He's a good personal friend of mine, and he's going to talk about cartilage resurfacing for the patellofemoral joint.
It's a great honor to be here with such great faculty members. I'm going to try to go through this quickly and get through a lot of the slides. No pertinent disclosures. When you look at the menu of treatment options for cartilage transplant or just cartilage work around the patellofemoral joint, it ranges from lavage, shave, and chondroplasty. Don't forget that in some of our athletes in season to get them back to play. There's surface-based or what we call non-structural work, including microfracture. We'll get into microfracture plus. We'll talk about minced autologous cartilage with fibrin glue. We'll talk about juvenile particulate articular cartilage, which is an allograft, bone marrow aspirate under a patch, and then we'll get to one of the gold standards, which is MACI. Then we'll get into structural grafts, talking about, Oates autograft and then osteochondral allografts. And then we'll get into some of the other things. This slide is constantly updated as new things come out, AMIC, Cardiform, and more. When you talk about considerations that you need to consider if you're going to do cartilage work around the knee, and specifically the patellofemoral joint, you're talking about defect size, involvement of the subchondral bone, the depth of the defect, chondral versus an osteochondral issue, alignment. When you start looking at the patellofemoral joint, it's specifically, you need to consider TTOs or tibial tubercle osteotomies to unload that joint to get better outcomes. And then also in the general grand scheme of things, looking at meniscus and cruciate deficiency when you're talking about cartilage work around the knee. When you talk about cartilage and cartilage grafts around the knee, it really is this stool concept where you're looking at limb alignment, joint stability, and then meniscus integrity as all being crucial components to supporting the cartilage. Other variables, age, patient's a contact athlete, focal versus multifocal. We talked about the status of the menisci and cruciates. Prior surgery, did they have a microfracture? Is there subchondral bone involved, making MACI potentially not an option? And their expectations and ability to participate in post-op rehabs. All these algorithms about what to do, it always confuses me and it constantly changes. So I don't think of it that way. My approach is that when there are larger lesions around the patellofemoral joint with subchondral involvement, I'm considering an OCA. Larger lesions without bone involvement, I'm thinking MACI. Then smaller lesions that I can solve with one plug, 8 to 10 millimeters, Oates, but it's harder in the patella, and I probably shy away from that in the patella and lean more towards an OCA. And then when you really have smaller lesions in the patella that are painful, despite conservative treatment, any resurfacing option that I describe will probably work as long as you do a TTO. Don't forget chondroplasty, especially in in-season athletes who are having recurrent effusions. I think this is certainly something that is overlooked now. And a lot of the things that we do in pro athletes to get him through, the great thing about it is I often will do a MACI biopsy at that time. And a lot of times these patients don't come in for future cartilage work. I consider it for smaller lesions that are acute with concurrent removal of loose bodies. And I really want to avoid any overly aggressive debridement. Osteochondral allografts, this is my workhorse, one that I do. I think, one of the challenges in the patella is really the technique and grafting it and putting it in the correct way. I use it for when there's an osteochondral problem, when there's bone problems as well. When there's underlying bone marrow and subchondral cysts where you need to have that replaced, or you're dealing with a postoperative situation, a failed microfracture, or something that involved penetrating the subchondral plate. When you look at a lot of the outcomes for this, the patella allograft survivorship is always less than in the medial femoral condyle or lateral femoral condyle. And a lot of that has to do, when you look at this data, especially William Bugbee, whether there was a TTO or tibial tubercle osteotomy added. And I know, Will, he does not, do tibial tubercle osteotomies when he's doing an OCA of the patella. And that may impact some of these outcomes. When you look at the femoral trochlea, interestingly, on the femoral trochlea, the survivorship is much better. You're looking at graft survivorship with this study at 100% at 5 years and about 91% at 10 years. The key to understand is always do a concomitant osteotomy. A TTO in these situations, you can measure the sagittal posterior displacement of the tibial tubercle, but unloading the patellofemoral joint really improves the outcomes of these cartilage transplants. When you look at the comparison between MACI and OCA, typically they're equivalent unless you have multifocal lesions, which tend to do better with MACI. And I think when you really sum up the keys to doing a good osteochondral allograft of the patellofemoral joint, we know it's challenging. Spend your time, really precise fitting and a smooth surface is the key. It's increasingly popular as a primary or salvage procedure. I think key, if you're doing cartilage work around the knee and around the patellofemoral joint, osteotomy, osteotomy, osteotomy. Fix the malalignment simultaneously to improve your outcomes. And with patellofemoral joint, do a tibial tubercle osteotomy. When we look at MACI, used to treat surface lesions, cartilage treatment for a cartilage problem, minimal to no underlying bone marrow edema. There are cases where you could do sandwich technique, but for me, it's generally for a cartilage problem. There should be a normal subchondral bone plate to allow the cells to adhere to. And for me, any MACI around the patellofemoral joints getting a TTO. When you look at some of the initial data, very concerning. New England Journal of Medicine, one of the initial reports with the old ACI technique, the initial results were very disappointing with a high failure rate in the patellofemoral joint, specifically the patella. We began to understand that TTOs are important, improved ACI techniques, suturing techniques, fibrin glue, and addressing concomitant patellofemoral malalignment, and then unloading the patellofemoral joint with a tibial tubercle osteotomy became extremely important, and the outcomes improved. When you looked at multi-center experience combined with TTOs, 84% good to excellent follow-up at 4-year follow-up. This study looked at, again, isolated chondral defects with ACI, again, with a concomitant tibial tubercle osteotomy, better outcomes. Then we get into MACI. Now there are a bunch of studies looking at MACI, which the cells are grown on a scaffold for you, making the surgery even easier. Multiple randomized control trials, so good body of literature showing that the outcomes are great. And they're even better when you have a trochlear lesion, you're doing it for a trochlear lesion versus patella lesions alone. That has a lot to do with the addition of a tibial tubercle osteotomy, where some people even go as far to say that they can avoid a TTO with a trochlear lesion. I still think you should measure the sagittal tubercle displacement or posterior displacement to see if it's a negative and then decide. But really, for me, almost always a TTO. MACI is, I think, an easier operation, less surgeon dependent, better instrumentation. You still need to consider unloading the patellofemoral joint, become comfortable with TTOs. It's more versatile, easier to take a lesion and shape it to the implant. And there are better results compared to OCA in the patellofemoral joint. Tough to tell. I think if you get good and comfortable doing OCAs around the patellofemoral joint, the results will be equivalent to the MACI procedure. What about OATS? Again, very little in my practice. I think it's hard to do taking a graft either from the intercondylar notch or the lateral or the medial trochlea area and then putting it at the patella. It's right there for me, and I've had a lot of issues where patients have patellofemoral pain after I do the graft. And the problem is that the cartilage, when you harvest it from those areas, is much thinner than the native cartilage of the patella, which leads to a mismatch, increased stress at the cartilage bone interface. And when you really break it down and look at trochlear lesions with odes versus patella, you still have an issue where even comparing patella and trochlea, you're still going to have suboptimal outcomes with patella lesions. Again, some of the moseoplasty stuff initially showed excellent outcomes, but when you compared it to his Hangoti's condyle work, it was always not as good as his condyle work. Juvenile cartilage transplant or implantation is allograft de novo, which is juvenile bits of cartilage where you'll put on and leave it stuck there with glue. Again, some of the initial reports, reasonable. I don't use this anymore. I've had some suboptimal outcomes. It's very expensive, but there's fill there, and it is an option. I think it's expensive, and I think with some of the other availabilities that we have better options to deal with in the patellofemoral joint. Don't forget about microfracture. Okay, but I do forget about it because after about 24 months, look at the failure rates that happen. And then when you focus on the patellofemoral joint, the failure rates are even higher. What about microfracture plus? The idea of doing a microfracture, adding an allograft extracellular matrix, you're mixing blood or PRP there, seal it with fibrin glue. The results have been promising. There's some improved outcomes, better cartilage fill that's seen there. So for me, this is a great option, and especially of the trochlea. When you look at minced autologous cartilage, again, you're taking particulated cartilage, you do it from a notchplasty, put it under glue. Again, what are the results? And a lot of this cartilage work, especially for these smaller lesions, is difficult to interpret because almost always the results are uniformly good. And I think when you look at this data, they're not focusing on the patellofemoral joint. A lot of it's focusing on condyle work. Same thing with bone marrow aspirate, covering the defect with a patch, injecting bone marrow under it. Again, tough to tell. Defect size as high as 6.5 centimeters. Hard to believe that this would work, but there's good outcomes that are reported out there. AMIC or autologous matrix-induced chondrogenesis, cartilage defect, you're preparing the defect, doing the microfracture, and then suturing in a collagen membrane or glue fixating. And with the idea that you're containing the clot there, allowing the cartilage. Again, a microfracture plus type of technique. And then Cartiform, which is an allograft freeze-dried with cartilage. Again, it's been described in the patella. I think this is a hard sell for me, especially the cryopreservation of the cartilage. I don't really believe that the cartilage survives. So in conclusion, the workhorse, for management of patellofemoral chondral lesions in my hand is MACI or OCA. Always consider an unloading osteotomy for lateral and inferior base lesions to the patella. And some data has come out that any type of anterior medialization that you do, you're unloading the entire patella. So really, a lot of this concern for medially based lesion, you're overloading it. It seems to be that as long as you're doing a 60-degree cut, the whole patella is unloaded. And then again, for centrally based lesions, they'll also benefit from a tibial tubercle anterization. Thank you.
Very good. Thank you much, Laith. All right, that covered a lot of ground in a short period of time. So that's great. So we have, if I can pull this up, I saw a question come through, and so we'll see. Petri, I'll see what your thoughts are on this first. One question is, any recommendation for the pediatric population? Do you wait and observe? What sort of like surgical algorithm do you have? And I'll kind of give a specific example. Let's say that you've got a how young of patients do you see, Petri? Let me ask that question first.
I see very young,
Okay, very
any
good.
age. Yeah.
So if you have a prepubescent patient, let's say Tanner stage 1 or 2, male or female, with a convex proximal trochlea, has been dislocating since age, 7 or 8. Let's say that this is an 11-year-old male at this point, and they're miserable, and you feel like something needs to be done. You know, patella height's normal. It's purely dysplasia. What's your algorithm there? How would you manage that person?
Yeah, I see. Those are the tough ones. It's easier, quite often they are females. It's easier to have like 10, 11, 12-year-old female. They might have maybe 2 years, 3 years under growth plates closer, and then therefore it's easier to wait and see. But in males, it's much more difficult as they grow until 15, 16, 17 years, and therefore basically what do we have as an option is just an MPFL. If there would be like patella alta, very high riding patella, we might imprecate the patella tendon, put the patella a little bit down, but it's quite often the case that we need to discuss with the family, with the patient, that perhaps MPFL reconstruction is a bridging procedure, and it might fail within few years, and then we need to address the bony morphology when the patient is a little bit more closer to the skeletal maturity, and I have certain tools for assessment of the skeletal maturity. It's very useful if your healthcare system, we have in our healthcare system, we have school healthcare which does the assessment each year. What is the growth expectancy based on mother and father? And we could see whenever it closes to a decline, the curvature, we probably can do safely a trochleoplasty 12 months, year and a half before skeletal maturity. We do not have data on that, of course, but most likely it's safe at that point. And I would say in females, as the most patients are typically females, it could be at any point post-menarche that the trochleoplasty is already safe. So that's something we need to discuss with the family, of course.
Yeah. There's a German study that showed that if they had 2 years of growth left or less, that you could at least do a thin flap and be okay. I have a decent amount of pediatric patients, and so I've kind of used that. I will bridge a prepubescent patient, tell them it's probably going to fail, and then revise them when they get a little bit older. I think we follow the exact same protocol in that regard. Laith or Dave, do you guys have any other comments on that?
What I have as a comment is that the very young population that Petri is talking about is tough to treat from my point of view, because you cannot address when it starts very early in the life. It means that you have huge abnormalities, and especially on the trochlear side, and it's tough to propose only the MPFL that you can do at that age, knowing that probably a few years later they will have a recurrence of their patellar dislocation. So most of the time I try to keep them understanding what's going on, and wait until the growth is finished. And you can even when the growth is not totally finished, you can do some bony procedures with not huge complications.
Yeah, I agree, Lee. I like that 2-year mark. I think I had a case that I sent you on. She was actually 11 years old, but her growth plates were closed already, and we did a bone age, and it ended up that she was much closer to 14, and she did quite well with the trochleoplasty. I think the other thing that we often overlook is coronal alignment, guided growth, excessive valgus that can be done in addition. Unfortunately, we don't have guided growth for the trochlea, but on some of these young kids where they're in excessive valgus and their patella is not riding well, when you do some guided growth and you start getting their patella back in place, it can start reshaping the trochlea a little bit. So I've seen that as well. It doesn't happen all the time, but for me, looking at coronal alignment and its impact on patellofemoral is important as well.
Yeah, that's another good point. Is like it can be multifactorial in these young people. The worse the pathology or piling up of pathologies are will cause them to dislocate a little bit earlier. So if they've got some valgus, that is a very nice thing to be able to correct in the pediatric population with a guided growth as opposed to an osteotomy. So that is another good tool.
Yeah, I think one thing which helps a little bit is that when we have these very severe congenital dysplasia patients, they typically tolerate the J tracking until age 8, 9, 10, and then become symptomatic only after age of 10. And basically you can follow, wait and see for a couple of years, and then you address them.
Petri, I have a question for you. Did you observe a change in the shape of the trochlea after doing an MPFL on a very, very young adolescent?
Basically, I haven't done that kind of study, but I do have some follow-up data on the adductor tendon MPFL on very young kids.
Yeah.
And I believe that, you know, after age of 8, 9, 10, which are typically the age of patients, it does not change after that.
Okay.
So
you have to do this. If you do surgery, you have to do that before 8 or 9.
Maybe something like that.
Yeah. Okay. Interesting.
Yeah, we have a study that's getting published, and we looked at skeletal maturity a little bit, and I've done well over 100 open physis trochleoplasties, and I've got one growth disturbance in a prepubescent 12-year-old male. That's it. I even have a couple 10-year-old females that did not get a recurvatum deformity. And I've had my general cutoff has been pubescence, especially for the males. I think it's more important, to Petri's point. But at least with the thin flap, with my experiences, the physis really does tolerate that quite well. And in the study that we followed all those. We have x-rays on all those patients, and we did not have observable growth disturbances after that, even if they had 2-3 years of growth left. As long as they had secondary sex characteristics, it was very, very well tolerated. So anyway, that's nice, because they're pretty miserable,
It's a very good point, and the study that you have done is really interesting in the way that you're allowed to do some bony procedure even if the growth is not finished. And for me, it's definitely the best, because you correct all the anatomical abnormalities only one time, and that's very good.
Yeah. All right. So I have a few questions that I want to kind of run through each of the different, each of you guys, kind of specific to your talks. So first off, Petri, what are your thoughts on some of these studies that have come out? And I'm not trying to be malicious towards anybody, but some of these studies that have kind of said MPFL is really all you need for most people. What are your thoughts on some of those studies?
Yeah, I think we still, even though we're getting better proms, the Banff patellar instability, I really do like that, but still I think it's a issue sometimes that can we really differentiate the result if we take a risk, like over tensioning MPFL in some dysplastic patient or something like that. Of course we get it stable, so the redislocation as an outcome is not a good endpoint. I would say we can stabilize the patella in any kind of surgical tool, basically, and therefore also, and another point is the follow-up. Whatever we do, we might get stable patella for a year or two, but what happens in 5 years or 10 years? What is the risk of secondary cartilage wear or other problems, subjective symptoms as subluxation or pain? I'm not sure if we actually do not know that. already. So therefore, I think there's a high risk if we try to address severe abnormality patient with isolated MPFL reconstruction only.
Yeah. You know, there was to your point, and just for the audience to clarify, what Petri mentioned was what's called the Banff Patellar Instability Instrument, which is a disease-specific patient-reported outcome tool. Some people will also call it the BPI as well. There was actually a study published just in the last couple of months in AJSM showing that the patellar instability population is unique with regards to the knee. And if you compare the BPI or the Banff to, they called it a disease-specific PRO versus region-specific PROs like IKDC, KOOS, WOMAC, et cetera, Lysome, activity scales, that there were ceiling effects that were present in these other PROs, and that the Banff or the BPI captured this population better than the other studies do. So I think that is, I agree with you. I think that is probably, I know that there is I think is it Norwich, I think is another disease-specific outcome score. But I think that is, I think that's what we should be using. And I also, in my own humble opinion, I think that a lot of these studies, whether purposeful or not, had a lot of selection bias where they said, oh, we had Dejour A, Dejour B, Dejour D, but very few of them actually measured bump size and different things like that. Because, one's interpretation of a B can be very different from person to person. And so I think that the risk is that they were kind of selecting out people with lesser degrees of anatomy or pathoanatomy. That's, I just think that that's something for the audience to keep in mind, that there is definitely a certain group of people out there that need more. Like, I don't think that just applying MPFL to everybody and then seeing how it goes is the right strategy.
That's why you need to use MRI and measure and quantify. And if we do that, because everybody can make it now, we can compare all the different populations. And because, of course, you have multiple studies published with very good results, blah, blah, blah. But we don't know exactly if we are talking about the same patient or not.
Yeah. And that brings me to the question I wanted to ask you. So you made a very good point in your sort of discernment of the degree of dysplasia, flat with or without a prominence, because that's a very, very interesting point. And so flat, you're going to determine, flat or convex, that's going to be an axial MRI evaluation. With or without the prominence, are you using X-ray as your principal determination of prominence, or are you using like sagittal MRI? Are you using that MPR mode in your MRI to help determine that?
I used to take X-rays and CT scan at the beginning to look at the shape and to look at this proeminence. And definitely, if your trochlea is flat or convex and it's at the level of your anterior cortex, you don't need to do a trochleoplasty, and the dislocation pattern is not so high. If you have this bump, this proeminence of your whole of the groove of your trochlea, it increased dramatically the effect of the dislocation pattern. So that's why when you use the MRI, you can measure it. The threshold is 5 millimeter, and it is exactly why in the old classification we have this type C, which was a flat or convex with no proeminence. Now we move to the type 2, and the type 2 definitely, if you can do an MPFL, for example, okay, but your patella might be not so stable, and it might be interesting just to distalize 5 millimeter to engage the patella in this flat trochlea. So it's much more accurate, and definitely I have changed my indications quite a lot for using this new way to analyze your PF joint.
Okay, and so the 5 millimeters, you're measuring that on a sagittal MRI. Is that what I heard?
Well, it's not. You can measure it on axial or you can measure it on sagittal. The most important is to use the MPR mode to make your two condyles aligned to be on the big condylar line. It is exactly the same as when you have a bad X-ray and a good X-ray, but you can do it with your PACS or with your viewer, your X-ray viewer. It's very powerful.
Yeah.
David, does the C, having the C, does that change whether you do anything to the tibial tubercle? I know you don't do many of them, but my question is, having a C, if you look at the Jupiter data and a lot of their trochlear dysplasia patients, a lot of those Cs that they just did an MPFL, MQTFL had higher, recurrence rates. Are you doing anything in addition on those Cs outside of the MPFL, MQTFL?
Yeah. Because as the trochlear is not congruent, if you do the MPFL, it's okay. It works, and it may work perfectly, but definitely your patella is not engaged in anything because it's in front of a flat trochlea. So in those cases, I don't want to face a recurrence, and I overplay for sure in the way that I'm doing a 5 mm distalization just to engage the patella into the trochlea. And the second thing, which is very interesting, is to look at the sagittal engagement of your patella on the MRI, and the normal values are 38%, and if your patella is less than 38% of engagement, be careful because it's a functional patella alta, and you may do a little bit more than an MPFL.
Interesting. And I have a question for Laith on some of this cartilage resurfacing stuff. For patellar osteochondral grafts, I do a lot of them as well, and they're challenging. They are harder. Patellofemoral osteochondral grafting is harder than the condyles. It just is, because the surfaces are more irregular and you can't match them as well. What imperfections are you willing to tolerate? Because I think they're unavoidable when you're doing, say, a patellar osteochondral graft. Is there areas of mismatch that are more or less tolerant for you?
I mean, for me, the more medial that I have the offset is where I seem to be getting into trouble. If there's more of a medially based offset, so I'm sorry. If there's more of a laterally based offset, I have more of a problem. So I'll allow more of a medial. If it's going to be recessed a little bit, it'll be more on the medial facet. For me, it has to be perfect laterally. That's where I seem to have the issue. And it's unfortunate. There are times where I've recessed it, thinking that over recessing it would be better. And they've still, continued to have issues. I think for me, Lee, and I'm sure for you, the goal is to try to be as perfect as possible. And I spend a lot of time back and forth making sure that fit is good and there's no low riding errors and no high riding errors.
Yeah, that's it's fun, but it's challenging. And it's definitely for Petri and Dave. I know that in the States we have cartilage options that I think that's inconsistent with other parts of the world. Like, what sort of cartilage algorithms do you guys have in your areas of Europe?
Yeah, basically the limitations in Europe, I think, are the allograft. It's fresh allografts, hard to get those. We do get some. We definitely do get any juvenile allograft or things like that, and also can do amic and minced cartilage nowadays. But I was just wondering, Leith, can I ask a question about?
Sure.
You mentioned that if you do a chondroplasty and you take some cartilage for subsequent need for MACI or something, how does your system work? How do you manage with that?
Well, we take it and they just store it, and they don't necessarily charge them. They do. I would say about 50% of those patients end up not going for MACI, which is a pretty high amount, and they bank the cells. I asked them how much does it cost them extra. They said it really doesn't cost them. It's the process of putting the cells on the scaffold and creating the patch that they do. So yeah, I would say that 50% of my patients, after I do a chondroplasty on, and I biopsy them, do not go for additional surgery.
And Dave, how do you what options do you guys have in France currently?
Well, we don't have too many options in France for cartilage surgery because we have no reimbursement. So I don't do at all. I never do any cartilage procedure except remove the flaps. And I would say all my results, my long-term results are done like that. So if you give me some results are more than 15 years follow-up with no arthritis, I would say, okay, perfect. Until I have a long-term follow-up showing me that the cartilage are much better than removing the flaps. I would say, okay, but I will probably be dead at that time.
Yeah. Do you think that that's a role for TTOs? You know, because my admission here is I have not done a TTO of any variety for almost a decade. Because I found the trochleoplasty to just be so powerful in improving the contact areas, and I treat patella alta with an imbrication regardless of the age of the patient. But I do believe that the TTO does offload the patellofemoral joint. I think that's true, and I think to Laith's point, like about how TTO improved cartilage in the patella, I suspect that a lot of those patellar chondral defects were associated with some degree of trochlear dysplasia, and that's why the cartilage repair didn't work that well. So they offloaded. But do you guys find that, Dave? Does that figure in at all? Like if you've got a big defect, hey, I'm going to anterize the tubercle a little bit. Does that play into your algorithm at all?
I don't believe too much in the anteriorization of the tibial tuberosity because the biomechanics which comes from Mackay a long time ago showed that you need to anteriorize more than 2 centimeters to offload your PF joint. What I believe in is that if you move up or down the your patella, especially in terms of distalization, you will change the contact area of your patella, and you will definitely improve the pain of your patient. But arteriorization, I'm not really in favor.
That's very interesting. Well, that makes me feel better about my choices. So,
Yeah.
yeah. Well, very good. Well, we are at an hour and 2 minutes on the webinar. I know we're scheduled for 60 minutes. So I want to thank you guys for taking time out of your day to come. Laith, thank you for breaking from the OR for a little bit for us. I hope they're not waiting too much for you.
No, we finished.
Oh, okay, good. All right.
Thank
Oh,
you
very
so
good.
much.
Very good. Yeah. So thank you guys for coming in and joining us for this. I think we had a good showing. Oh, yeah, sorry. Go ahead.
I say yes, so I will go to New York, London with Laith, and we will do a combined surgery. I do the trochleoplasty, and you do the cartilage stuff.
Yeah.
I'm ready.
Yeah.
Let's
I
go.
think, yeah, I think Laith and I both have experience with that. I've done a lot. I mean, I do most of my cartilage resurfacing is going to be on the patella. But I have done MACI or a patellar OCA concomitantly with the trochleoplasty, so it happens at the same time. And I have treated full thickness chondral defects on the trochlea as well. I have had a limited experience with Cartiform. I've used that a couple of times for full thickness trochlear defects, and that, you know, you can still elevate a full flap with that defect in place. You can reshape it, you can get things held down, and then the Cartiform is nice because you can kind of just cut it to fit. And I've just held it down with the trochleoplasty sutures. And I've had, in the limited numbers of those I've done, they've done well. But as I've gotten more sort of facile with trochleoplasty in general, for those full thickness defects that are more osteochondral in nature, I have been able to actually put a fresh allograft plug in there. I've done that a couple of times. And I've also even been able to do a MACI on a trochlear defect. If I just leave a thick enough of a flap with some subchondral bone, you know, I can reshape the trochlea, push it back down, and then I can scrape off the chondrosis and I can put a MACI patch on there. And I would say that's actually a really nice, the thick flap technique would make that very, very easy because you're leaving about 5 millimeters of subchondral bone present. So the answer is yes. I have a pretty decent experience with doing those concomitantly.
Yeah.
I would add the only thing, Lee, I think,
Yeah.
look, as you're learning and on the learning curve of trochleoplasty, for me, I was doing trochleoplasties, adding them with a TTO and a patella MACI. For me, I was not as stressed out as I was learning the technique of trochleoplasty because my feeling was, even if I didn't do it perfectly, I had the TTO and the unloading and the medialization as a backup, you know, for me. And I think for people who are just starting on this journey, that's a good way to, you know, look at it and approach it.
Mm-hmm. I agree.
Yeah. So you can do a lot at the same time.
Oh,
yeah. So, Oscar, do we have any more questions? I want to make sure we get all the questions answered before we sign off. And it looks like I don't see anything on the chat. All right. Well, good, guys. Thank you very much. I appreciate it. It looks like we had a good showing. So thank you for your time. I know that this will be available. I think Oscar made a comment that this will be available
24
on
hours,
YouTube.
yes.
Yeah.
Next day on YouTube.
Yep. Yeah. And at arthroschool.com. So great.
Thank you so much.
Thank you very much.
Thank you, everyone. Good seeing you guys.
Okay.
All right.
Bye-bye.
Thank you.
Au revoir.